How much of Airway is being implemented in terms of, screening, acknowledgement, or how much of a role is there in the hospital? Welcome to episode 25 with the most special guest, Dr. Ed Buchanan. Thank you for coming to the studio.
Thank you, David.
For those of you who don't know Dr. Buchanan, he is the most talented surgeon on the planet. He could fix your toes, your fingers, and your face all in the same day. He's a craniofacial plastic surgeon, head of surgery at Texas Children's Hospital in Austin. We met here in Houston when you were in charge of the plastics and craniofacial department. We're very blessed to work together. And a lot of interesting things to discuss about surgery. A lot of people that are watching this podcast are really interested in orthognathic surgery, in maximizing function, and a lot of people are also interested in maximizing aesthetics. So who better to have here in the studio than a plastic surgeon who's also a master at jaw surgery?
Thank you, David. Thank you for the very nice introduction, and totally undeserved, but I appreciate all the kind words you say. Yes, we have worked a long time together and doing very difficult cases, very difficult jaw cases. I think our relationship is special because a lot of kids who have difficult craniofacial conditions, a craniofacial surgeon and an oral surgeon matched together makes the results so much better. Mm-hmm. So I've just been blessed to have David in Houston when I worked in Houston. But now I'm in Austin at Texas Children's Hospital in Austin, and we're building another great team up there. And so if anybody wants to come check us out, please do.
Yeah, so if you're in Austin or surrounding areas and you have a kid or interested in jaw surgery, craniofacial surgery, it's one of the best departments in the world right now, led by a really talented and modest surgeon. So reach out, look for Ed. I gave a interview with Ron Ead on Jaw Hacks about 3 years ago, and he asked me, who do you think are some of the best jaw surgeons, orthognathic surgeons, besides yourself? And I said Ed Buchanan.
Oh, I really appreciate that. That's great. That's great. We have a great team. There's a guy up there named Richard Hopper, who's also another craniofacial surgeon. Yeah. And so he's there with us, and but we have a great team. But a lot of things I do in the operating room is because I learned it from David. So there's a little bit of cross training right here.
Yeah, definitely. We learned a lot from working together.
That's right.
For sure.
That's right.
So I do want to get into, I hear a lot from people. I'll post some things and they'll say, hey, how about will you do a Lefort 2 or a Lefort 3 electively? And I always try to make a point that's we don't elect to do those operations for most people. Those are really should be reserved for real craniofacial deformities. But I do want to get your insight into this to help the community out there is in terms of an education point. What is the difference between these procedures, Lefort 1, 2, 3, and monoblock? And where do you think, which patients are appropriate candidates for these surgeries?
No, it's great. It's a great question. And a lot of the public probably asks, why do you call it a Lefort? What does that mean? Well, there was a gentleman named René Lefort, who's a Frenchman, who by dropping skulls off of tall buildings was able to figure out where the facial skeleton would break more than not. So what he was able to do was determine where the weak parts of the facial skeleton were. And so based on that, we were able to leverage what he found and then actually emulate that in the operating room using very controlled saws and surgical techniques. So a Lefort 1 essentially is an operation where you make a cut in the bone, in the facial bone, just at the level of the base of the nose and above the tooth roots. And so it's just sort of across this area. A Lefort 2 actually comes a little bit higher where you come across the bridge of the nose, but you don't include the cheekbones. You essentially just go across the bridge of the nose and down where the rest of the Lefort 1 is. That's specifically for people who have mid-face hypoplasia, but that extends up into the nasal frontal area. And so you're really trying to move the nose bridge and the mid-face and the upper jaw forward. You'll see those in a lot of patients, like achondroplastic dwarfs will have those. And so we'll do that on those patients, but other patients can have it too. We don't normally offer, and then a Lefort 3 is an operation where you actually include the cheekbones. So the cut is across the bridge of the nose, under the eye, and including the cheek, and then back behind the upper jaw, so that you actually move this whole segment forward without the forehead. So it's this whole segment. We do that operation a lot for kids who have syndromic craniosynostosis. So something called Cruzon syndrome or Pfeiffer syndrome or Apert syndrome. And there's different variations of a Lefort 3 operation that you can do, meaning you can move the cheeks less far forward than the nose, depending on how the facial presentation is.
Yeah.
And so that's really up to the surgeon to decide that and to do an analysis before surgery to figure that out. Now, the caveat to Lefort 2 and 3, and even of Lefort 1, or any facial surgery like this that's extensive, is we don't necessarily offer it for cosmetic reasons. It's more of a functional operation. So a Lefort 1 operation that you do a lot of and do it very well, probably the best in the world, is done for airway purposes and to order to decrease the nasopharynx so that someone can breathe through their nose a lot easier. A Lefort 2 is the same deal. You increase the nasal airway, but you're also increase the amount of projection in the nose, but that also increases the nasal airway. And the Lefort 3 obviously moves the whole mid-face forward. But the deal with those is they're functional, like I said before, and they're hard surgeries to go through. There's a lot of blood loss. They can have big incisions. So the Lefort 2 and 3 actually need an incision in your scalp, so in your hairline, whereas the Lefort 1 you can get it done through the mouth. And so you don't really want to do that for aesthetic reasons, because there are complications to it. And whenever you decide to do surgery, you always have to weigh the risks versus the benefits. And that's something that you and I do all the time, because we don't want to hurt people. We only want to help them. But sometimes in the process of trying to help somebody, things can happen that you don't expect, and that can end up hurting someone. So you always have to be very careful with your patient selection.
Yeah, absolutely. So what do you say to the patients that feel that they obviously need orthognathic surgery? They feel like they really want better mid-face support, cheekbone support. I do feel that cheek and mid-face improve a lot with a good orthognathic surgery, and even a traditional Lefort cut, or maybe even a high Lefort cut. Yeah. But people that want more, even forehead augmentation, what are your thoughts on that in terms of the cosmetic desires? Yeah,
I mean, there are a lot of good implants that you can use. So the first line, usually when it comes to wanting more projection of the cheeks or the forehead, is usually fillers, some facial fillers that are that you can have injected in the clinic setting. That will give you more projection, but there's a limit to how much you can get, and then there's a limit to how many times you can have that, and then some of those fillers will go away with time. So the other option you can have is you can have implants done. Usually the implants that we do are made out of porous polyethylene, and those are custom made. They can be custom made, or they'll have them there off the shelf that you will shape in the operating room. But they can be made for the cheeks, they can be made for the dorsum of the nose, they can be made for the forehead. So those are all definite options that you can use as a quote-unquote camouflage technique, where you don't have to actually go cut the bones of the face. You just onlay and you further augmentation.
Safer than a Lefort 3.
I think so. Less blood loss and things like this. So,
yeah. Okay.
Yeah.
So besides blood loss, any other risk factors for something that invasive?
Oh, Lefort 3?
Yeah.
Well, yeah, the biggest risk for a Lefort 3 is a CSF leak, which is because you're moving the mid-face, the part of the face that's right below the skull. There's a very thin layer of bone at the level of the nose, at the cribriform plate, and if you fracture that when you're moving the face, then you'll get a CSF leak, and that's a hard thing to treat. You have to have the right neurosurgery team there with you, and you have to have some patience. Every now and again, you have to go back to the operating room and stop the leak. It's not common, but if you're not careful with it, you'll have to do that. But that's one of the bigger complications that you got to be on the lookout for when you're doing the surgery. Yeah. The other one is it's a big surgery, so blood loss. And so you have to be ready to transfuse somebody.
Yeah. It's great. How long ago did you move to Austin?
About 2 years ago.
2 years ago.
Yeah.
So that's a different role. I mean, you were in charge of craniofacial fellowship at Texas Children's, in charge of the plastics department. You operated a lot. I remember when you were there doing a lot of various surgeries at very high levels. Yeah. And what has the transition been to Austin? What's the difference in the role and responsibilities there?
Well, yeah. So when I was in Houston, my last role was the chief of plastic surgery, and then I was the fellowship director for the craniofacial fellowship, and that was awesome. Great experience. Great time leading a group of plastic surgeons. The biggest pediatric plastic surgery practice in the country here in Houston, and just a great group of people in a marvelous hospital. Anybody's ever been there, they'll tell you it's just a great place, a lot of caring people.
It is. It's a special place.
Just the premier place to be. Yep. And I know you work over there too as well with some of our cleft patients and other patients. So
yeah, it's been very rewarding, obviously challenging cases.
Yep.
But such a rewarding thing to give to that community that doesn't have a lot of access to providers like you and I.
No, absolutely not. It's a blessing that you're here and your group is here to kind of help those patients. Then I was asked to look at the opportunity in Austin. So over the last 10 years, something like 35,000 patients have left the Central Texas, Austin area to come to Houston to get care. And so what we did as an organization was strategically look at how can we better serve our patients. And one way to do that is to go to where they are. It's not easy to travel around. It's expensive. You got to get hotels and things like this. So the mission of the hospital was to provide a hospital in Central Texas, in Austin area, to help serve a lot of those patients. We'd also, just by being here, we've been treating them, but there's all those patients that maybe don't have the resources to get there.
Yeah, absolutely.
And so by being closer to home, you can actually treat them easier. And so that was a decision to go.
Yeah.
And
to that point, sorry, but a lot of these kids need so many visits that the back and forth is really a lot for
any family, especially a working family with you have two parents working and you got to take time off and travel and stay in hotels. It's just it's prohibitive. And so what you want to do what we decided to do as a healthcare organization was try to bring our care as close to our patients as possible, and we continue to try to do that.
Yeah. So I know that when you were in charge at here in Houston at TCH Medical Center, you had really developed an amazing multidisciplinary program, meaning that, when I got here 12 years ago, oral surgery, pediatric dentistry, orthodontics, plastic surgery really didn't mix.
Yeah.
Right? Everyone kind of did their own thing. And you as a true leader and visionary and someone that's really looking out for the best of patients, and this is a unique skill set that you have as a clinician and leader. You brought all these things together, right? You had a strong craniofacial orthodontic department within the plastics department. You started, I give you all the credit to starting the oral surgery partnership there, division in there. And pediatric dentistry was there, but there wasn't a lot of collaboration. But now all of them are very tightly knit, and I think that the outcomes for these patients and the possibilities, I mean, I've seen it, has been tremendous. Yeah, I can only imagine what now you've done in the past 2 years in Austin, but I want to hear about that.
Well, I appreciate you saying that, because it brings back a lot of great memories of bringing people together who care. I mean, that's really the most important thing when it comes to building these teams and these centers of excellence, for lack of a better word. And you can do it anywhere in medicine. You can have a center of excellence in heart surgery, in musculoskeletal care, in fetal care. Any of the specialties can have it. But the foundation of any team is the people who care. And the people who, care is like the action word for love. So they love their fellow human. They love their profession. And so they're going to be doing it no matter what. And so it was serendipitous that we had people in pediatric dentistry, oral surgery, craniofacial orthodontics, plastic surgery, ENT, otolaryngology, speech therapy. we had these people who all cared.
Yeah.
And so it made it easy, because you could just say, listen, I have some patients who have challenging congenital problems, and I don't have all the answers because I'm just a single entity.
Right.
But these patients, they span all the disciplines, and so you have to
Absolutely
bring them all in. But if you have the right people, it's a no-brainer. It works very easy, and not only that, it becomes a great working environment.
Yeah.
Because everyone's excited to be there, and they're also, when you have the most challenging patients, it becomes almost easier because you can leverage the people that you work with to kind of come up with the answers, because they're yes people. You say, listen, I got a problem I don't know what to do. Yeah, we can do this, we can do this. So you brainstorm with them, and then you can solve really hard clinical problems. And that's where the magic, I think, happens.
I think so too.
So in Austin, we're sort of a fledgling team now. We have our craniofacial orthodontist. Actually, we hired a guy named Hitesh Kapadia, who's been in the business for about 15 years. Nice. And then Rich Hopper, who we brought down. And there's a guy named Ibrahim Kansa, who we brought from Ohio State. And then we have a great otolaryngology team up there. We have great specialists up there. And that was the last 2 years was really recruitment.
Yeah.
To start a brand new children's hospital with all the specialties is sort of unheard of. If anything, in the news, you hear that pediatric programs are closing and they're consolidating. And we went up there and opened a brand new one with a brand new hospital. So it was a feat of magic just to do that. But by the same token, we've hired some really great people. A lot of people apparently want to live in Austin. Yeah. So, and we're at the ground level. We're going to be building our craniofacial clinic out soon, which will include plastic surgery, pediatric dentistry, and orthodontic chairs. So they'll all be in the same co-location. So the setup will be a little bit better. I don't want to say this out loud, but I will. A little bit better than we have in Houston right now. They're on different floors. Yep. But in Austin, they'll be on the same floor.
That's awesome.
And so they'll be right next to neurosurgery and right next to ENT. So the patient will come in and literally be able to kind of cruise the floor and see all their specialists in one jump.
Yeah.
So it'll be great.
I know you're uniquely positioned. We talk about Airway a lot. You've heard me talk about it.
Oh, yeah. Airway expert.
A lot.
Right? Yeah.
And it's not only through our collaboration and friendship, but your brother's an oral surgeon.
Oh, yeah.
Your father...
Dentist.
Yes. So you're uniquely positioned to have these relationships and insight. How much of Airway is being implemented in terms of screening, acknowledgement, or how much of a role is there in the hospital?
No, I mean, that's a great question. So obviously kids who have cleft and craniofacial conditions, they all can suffer from airway problems. Anyone can suffer from an airway problem, but congenital facial deformities tend to have
severe,
probably a higher proclivity to it. And so all of our patients are usually sent for a sleep evaluation, a sleep study, to exactly see, they're screened for snoring and sleep patterns and things like this in the clinic. But then if there's any concern, we usually send them for a sleep study. And that's hard to do for little kids sometimes because, it's a foreign place and they got to try to sleep there. And, so you could imagine that it's probably not always successful, but
it's a challenge.
It is one of the number one considerations we have with most of our craniofacial kids, because the airway is not a big area, and for it to go from good to bad only takes a few millimeters. And so they all need to be screened and then further evaluated if there's any concern.
We talked about fellowships. We both have led fellowships in our respective fields. And it seems that there's a diminishing amount of graduates who are interested in higher level of care. In oral surgery, a lot of people are interested in graduating and doing implants, wisdom teeth, bone grafting, but not necessarily spending an extra year learning how to be proficient with orthognathic surgery or head and neck cancer, these things. And I was surprised to hear that was a similar, I guess I shouldn't be surprised to hear that it was similar, but you're seeing a similar trend in that direction.
Yeah, I mean, the past number of years being the fellowship director, you kind of see the number of applications you get, and it has been going down. Plastic surgery as a profession is a very attractive profession. It gets a lot of, a lot of press. You see a lot of stuff on TV about it, so it's
popular.
It's pretty hot. Yeah, it's pretty hot. But there are specialties of plastic surgery, like hand surgery is a specialty, craniofacial surgery, microsurgery. These are all 1 year past a plastic surgery fellowship, plastic surgery residency. Those are not, from what I've seen, they're not as attractive in the last number of years, because I think people they just want to be done training. You know, it takes a long time to become a doctor, and then to become a surgeon, then to become a specialized surgeon. So a lot of people are just kind of fed up with.
They're tapped.
Yeah, they're done. It's enough. I've had enough. And so,
or their spouses.
Yeah, like, or their life circumstances suggest like, right. Listen, you're done. And because the light is there at the end of the tunnel. But what I would say to them is that most fellowships are only 1 year, and that 1 year will set you apart from everyone else who graduates from that fellowship or that residency by a long shot. And it will just give you a certain set of skills that, first of all, is highly marketable. So you'll be able, you should be able to go to any market in the country and find a good job.
Right.
But you also be that much more helpful to,
definitely,
to your fellow human, for lack of a better term. You'll just be that much more helpful. And at the end of the day, we're all trying to be helpful to people. At least that's what I try to be. And Absolutely. So if you can have a certain level of skills that makes you more helpful, that I only see that as a bonus.
Absolutely. And I do think that the demand is going to rise for these larger operations like orthognathic surgery or a lot of the things you do.
Well, definitely with you getting the word out, it's gonna get better.
We're definitely getting the word out. But I think the reason for that is, it's a much better operation than it used to be because of technology, and we've made advancements. Right. When we both started this, jaw surgery, if we're talking about jaw surgery here, was not what it is.
No.
We couldn't do what we're doing now, right?
Yeah.
Get in and out in little time, hour, 2 hours consistently, and not having to wire people shut, and getting people back to work in a week or two, keeping them in the hospital only one night. So because of the realities of technology and advancement in knowledge, the surgery is way more accessible. And because it's more accessible, there's obviously a lot of people that can benefit from this procedure. And that risk-benefit ratio is really going towards benefit.
Absolutely right.
So the numbers are rising. How are we going to meet this demand as
people got to come to your fellowship. Is what has to happen.
I think so.
No, I mean, you're absolutely right. When I was training and, before then, these operations were longer, they were more bloody, and I think the morbidity afterwards was higher. By you pioneering specific techniques with patient specific implants, patient specific cutting guides, and just the amount of operations that you do, the sheer volume, makes you technically probably one of the best craniofacial, the best orthognathic surgery in the world. And if anyone's considering that, like, you should be their first stop, obviously. But with that being said, you're absolutely right. I think patients need to be less scared about the operation, because the recovery is not as bad as it's played out to be if you go to internet sites and things like this.
Right.
It's a lot easier, but you also have to find the right person to do it. You got to make sure that the person doing it does it and does it a lot.
Correct.
And has a comfort level with it.
That's a key thing.
Absolutely.
I mean, it takes a lot of experience. And it's even more than experience. It's like the resources and systems in place to get through these is really important. But only surgeons that are doing these things have those systems in place.
What I like about what you do here is that you actually also bring in a naturopathic component to it, where you have patients use some things that are a little bit unorthodox when it comes to traditional medicine, like the echinacea and the things that will help with swelling and postoperative pain. That maybe you can avoid some narcotics and things like this.
Absolutely.
And so I think that is very key, because that's taking it to the next level, where you're actually considering the whole patient, the whole recovery, the whole process. And it really, I think, sets the patients out on the right foot right after the operation.
One of the things I picked up from a conversation we had together is Exparel.
Exparel, sure.
And ever since that conversation, we've implemented it.
Have you noticed difference?
Yeah, we've noticed a difference. It's been great. I mean, patients are definitely more comfortable. I don't hear pain. As a complaint at all. I just hear discomfort. But I think that's been a really cool made an impact on recovery for patients.
I don't own this drug or sell it or anything, but I've used it for a number of years on many different surgeries and on kids, because that's, I operate on children, and that's a big thing with pain, because they're going to be very scared. And most kids have very little pain if you use it. So, and we've done some studies on it too, just to look at bone grafting and after orthognathic surgery too.
Yeah.
It's definitely demonstrated benefits.
Yeah, that's cool. Appreciate that. Is there cultural differences in medicine in Austin and Houston?
Oh, that's a good question. I don't think I've been there long enough to notice.
To know that?
Yeah, notice just yet.
I feel that, I could tell you're coming from New York, that Houston, being in the medical center, is, I think, so much more collaborative than what I was used to.
Oh, yeah.
In New York.
Okay, yeah. That's a good point. I'll tell you, I don't know yet. I think maybe one of the reasons for that in Houston is that all the hospitals are right next to each other.
Yes.
So you can just walk out the door and go talk to your colleague.
Yeah.
Whereas Austin is separate. Like we have our own campus, but we're not close to any other hospitals.
Yeah.
And so you don't have as much of that collegiality just because you're not all co-located.
Yeah. Houston is unique in that.
It is absolutely right.
There were days, I don't do it anymore, but I think there was a day where I operated at Memorial. Memorial Hermann.
Yeah.
Methodist and TCH in the same day.
It's good. Yeah.
Because they're right across the street from each other.
You're the man. And it probably wasn't that hard.
It wasn't. And walk. But it's so unique.
Yeah. Yeah.
The other thing, I think we had this conversation before, is that there's, this medical center recruits so many patients, not only from Houston and greater Houston. And like you said, people were coming from Austin, all parts of Texas, but even South America. People are coming from all over the world to the medical center, that I don't think there's a doctor in the medical center that is competing for volume or patients. It's almost like there's way more than enough to go around.
That's right.
For surgeons, that they don't need another patient. Nobody here needs another patient. And I think that in New York, I think that was a component to it. It was like there was so much competition between surgeons in the specialty. Forget about surgeons outside of the specialty. Yeah. That it was like, what can someone do to get a patient? But here it's like, it takes that. It's just human nature, right? That's behavioral. There's a component to that. But it takes it out. Like, everybody has so much work that once you get that out of the way, it's like, okay, hey, Ed, can you help me with this case, right? Exactly. Like, there's a lot of that happening here.
Yeah, because the volume also brings that complexity.
Right.
So you're
and
like,
the complexity.
Okay, bread and butter cases, that's fine, but I got this really hard case. I've never done one, but you probably done one, and maybe how better to do it, and
let's do this together.
So let's do it together. Maybe you could teach me some things, and that is very helpful as a professional,
for sure,
who does hard things, and things that can hurt people if you don't do them well. And it's helpful to have people. I think parents appreciate that, or patients appreciate that, because they know that you're doing your best. You're looking out, even if you're looking out for them, even if it's something that's very, very rare. You're trying to get as many experts in the room as possible, and I think people appreciate that, because they know. Usually, people know when things are not that easy or straightforward. Yeah. They've been told no by a lot of people, and they find you as the fifth or sixth person, and they say, "Everyone says they're not going to help me. Can you help me?" And you say, "Yes, I'm going to help you, but I'm going to ask someone else to be there too, because I need some help." And so I think most patients feel good about that, because
they have a team that
exactly right
of high level people that are really taking them. And I think that's such a key factor here, that there's a lot of talent in Houston, and I think that collaboration has really made all of us better, and amazing things are happening.
That's right.
For sure.
There's no doubt about it.
Yeah, I'm sure Austin it's coming too.
Yeah. Oh yeah. Austin's up and growing, and the word is getting out that we're there, and families are very happy that we're there. And and so we're just going to watch the rocket ship go off.
Yeah. In that same breath, let's settle this. Who has better barbecue?
I don't know. I mean, I haven't tried all the places in Austin. I've only been there for 2 years, so There are some good spots. There's a place called Interstellar, which is, I think, ranked number 2 in Texas, which is
really?
very close to the hospital, actually.
Oh, that's nice.
It's right down the street. So
Yeah.
that's really good.
That's really good.
That's really good. But I've had great barbecue here in Austin, too. So, I mean, in Houston, too. So.
Yeah, I think one of our top rated places is Truth Barbecue. A lot of
Truth's
people will say.
good. Yeah.
But I think that's an Austin.
Is it an Austin
original?
Yeah, I mean, they got some spots up there.
Yeah,
about it.
Uchi's an Austin original.
Yeah, Uchi original. But I will say, it's a little different than the Uchi here in Houston.
Is it?
Uchi in Austin is a little bit more low key.
Okay.
Like the Uchi in Houston is kind of,
it's fancy.
It's so fancy, yeah. There you go. It's a little bit more understated.
Yeah.
And they're both very good. Don't get me wrong, but there's a little different vibe.
Yeah.
So when you go up there, you'll let me know what you think.
There's a lot of interesting people that are bringing attention to Austin, like Joe Rogan, Elon Musk. I'm sure some other names. Is there an influence there that you feel?
Well, the city is definitely there's an electricity to it because there's a lot. I just believe there's definitely a buzz, and so there's a lot of new people coming. There's a lot of migration, and there's a lot of growth. So that's happening, and the freeways are under construction, and a lot of new neighborhoods, and a lot of cranes downtown Austin. So it's happening. And there's a big tech migration, I believe, from California to Austin, which is quite interesting too, because you just have the growth. It's
like a new Silicon Valley.
Exactly right. There's a big Apple facility right there.
Yeah, a lot of startups, and
they're building
tech.
a big Samsung plant in Taylor, I believe, and so there's just a lot of talent and a lot of smart people coming to Austin.
Yeah, that's great. So all those surgeons in New York, look at Austin and Houston. We welcome people, right?
Absolutely. Come on down.
To these places. Ed, I know you're a very busy man, and we could talk forever.
We could.
But really thank you for coming to the studio.
Yeah, thank you for having me. This is great. Beautiful. You have a beautiful office. I encourage anybody to come visit Dr. ALFI.
Appreciate you.
He's a gracious host, and it's a beautiful place. A great view up here. Look right down on Rice Field, Rice baseball field.
Yeah, definitely.
Beautiful.
We'll always close it with who's your greatest basketball player of all time?
There's only I'm sorry to tell you, but there's only one of those. MJ.
I can't argue against that for sure.
MJ's the man. Yeah, you can't, it's hard to argue.
I think
with
MJ's the GOAT. I love Kobe.
Yeah, I love Kobe. I know you love Kobe. I love Kobe, but I
hard
grew up,
to argue against that raw.
Yeah, it was the
competitive athleticism.
I'll tell you the MJ story that I remember. I was little when I used to watch him, and it was it would always be the fourth quarter. There'd be 8 minutes left. The Bulls would be down by 10 or 11. And then the Michael Jordan show would start. Yeah, it was reminiscent of watching Tom Brady. Yeah. with 90 seconds left with the ball in the 20. You knew it was going to happen. He was going to score a touchdown. There was going to be 3 seconds left. MJ was going to finish the game up by 5.
Just give him the ball and get out of the way.
You get exactly right, and it's like that's how great players are. They know how to manage the clock. They know how to manage their players. They know how to manage all the components to get the result they want.
It's almost like they're in slow motion and slow everything down.
It's beautiful.
That's cool.
Beautiful.
Awesome.
Thanks.
All right.
Thanks for having me.
Thank you.
All right.